Assalamu alaikum. Today I am going to share with you a case of a 65-year-old female that I did. This patient had band keratopathy, a poor view of the anterior segment due to the band keratopathy, and adherent leucoma due to prior trauma, and a non-dilating pupil. I will go through all the challenges that I faced during this case. After injecting adrenaline, the pupil dilates to about 4 to 5 millimeter, and now I'm confident that I might be able to do the rexes. I carefully decompress the anterior chamber so that I can inject the trypan blue dye. I am staining the capsule because of two reasons. First of all, because of the band keratopathy, staining the capsule will provide a better view of the anterior segment of the anterior capsule, and secondly, it will be easier to manipulate the rexes if there is zonular weakness. Now, after injecting, trying to wash out the divaxyllocaine, I observe that the eye has become hard, which makes me suspicious that there may be fluid misdirection syndrome. Due to the weak zonules, I carefully inject some viscoelastic and I can see some dye. I carefully put some viscoelastic over the iris adjacent to the main incision, but as you can see, the iris has started to prolapse through the main incision. Now I'm pretty sure that some of the dye, even though I was careful of using very small amounts of dye, have gone through the zonules into the Burgess space. Now in these cases, I usually loosen the speculum, pull the speculum out of the fornix onto the lid to decrease the pressure on the lid, on the eyeball, and now using another incision, I push the iris back into the eye. This method works most of the time. However, in this case, it did not work. So, as you will see, it is not working. And now, as you will see some dyes coming out here. The dye is coming out, which was trapped behind the iris. So, in these cases, use very small amounts of dye, even though I was very careful to use a very small amount of trypan blue dye. However, still this complication happened. So in such cases, it is always better to be safe, so proceed with phacoemulsification after using iris hooks. There are two advantages of iris hooks. First of all, it causes dilatation of the pupil in such cases because the view is already compromised due to the band keratopathy, and secondly, it prevents the iris from constricting and making the rest of the procedure more difficult. If the iris prolapse, the pupil will still be sufficiently dilated to successfully complete the rest of the procedure. And here at this point, you will see that there is some wriggling of the anterior capsule, which will suggest that the zonules are weak. And at this point, please observe here. You can see the anterior capsule is wrinkling. It is not behaving normally, which gives me the suspicion that the zonules are weak. So I continue with the capsular rexes. After doing the capsular rexes, I'm glad I stained the capsule, otherwise it would have been very difficult to perform the capsular rexes in such poor visibility. To come careful hydrodissection, and this point is important to note that whenever you are inserting the phaco probe in such eyes where there is iris prolapse, always go bevel down and with irrigation off. Turn on the irrigation when inside the eye. Otherwise, if you have the bevel up, it will cause dragging of the iris root and iridodialysis at the main incision site. And here I have removed the last bit of cortical sheets, and you can see the band keratopathy with the red reflex in its background. Now I will inject a single piece hydrophobic IOL. It is better to use foldable IOLs in such cases in which. And now another very important point in such cases is always stitch the wounds where the iris is prolapsing, because in more than 90% of the time you will encounter a prolapsed iris on the next day if you do not stitch the wounds. And here I am removing the last iris hook. I have also stitched another side port and the case was completed successfully. Thank you so much for watching. Please give suggestions and comments. Jazakallah. So I hope you enjoyed the video. There are three very important take-home messages. First of all, stay in the capsule if there is poor visibility. Secondly, if loosening the speculum does not work, you can use iris hooks. And thirdly, always suture the wounds. In case of iris prolapse, you do not want the patient to go to the operating room the next day. Jazakallah.